management of hypertension and multiple responses to enhance cardiovascular health, a cluster randomized trial in Singapore. And I think we have about an hour, and we'd like to keep it very informal. So if you have any questions, please feel free to interrupt and ask the question. I have about 40 slides. And here's a brief overview of what I'm going to be talking during the next 40 minutes. So I'll start with the burden of CVD and hypertension globally in Southeast Asia, and then focusing on Singapore. And then discuss the challenges with regard to hypertension care in Singapore, especially as far as lack of awareness and control rates are concerned, and use of antihypertensive medications and how that conforms with the current clinical practice guidelines. Then discuss the evidence-based strategies for blood pressure control at the health systems level, and then and our investigator experience. And based on that, how we've designed the hypertension management trial in the polyclinics in Singapore, its aim, design, methods, and plan. So these are data from the Global Burden of Disease Study 2004. And as you know, hypertension confers the greatest attributable risk for death. And that's true for all countries and all regions of the world, low-income countries, middle-income countries, as well as high-income countries. Now, more recently, data from the Global Burden of Disease 2010 have been released by the Institute of Health Metrics and Evaluation. It's based in Seattle. And the data have been published in the Lancet recently, and these estimates have not changed. High blood pressure continues to lead the list of silent killers. And again, tops the list in pretty much, as I said, all regions of the world. And focusing in on the Southeast Asia region, if we look at these countries here, as you can see, 8 standardized cardiovascular death rates are highest in Singapore compared to other countries. And I'd like to again underscore that these are 8 standardized CVD death rates. And if we look at 8 standardized blood pressure levels, 8 standardized blood pressure levels are also highest in Singapore in men compared to other countries. And so I've already shown the tight link between blood pressure and CVD. Now, along with that, comorbidities, the diabetes and hypertension levels are also high in Singapore. And that's important to bear in mind, because when we are talking about treating high blood pressure, reducing high blood pressure, we also need to address these other risk factors among the hypertensive subjects, and that's important for optimal cardiovascular risk reduction. And I'm highlighting this here because we're going to come back to this point later in the discussion. And so just to look at these levels in Singapore compared to the other countries in the region. So very high CVD death rates, very, very high blood pressure levels in Singapore, 8 standardized levels. So it's not just aging population, it's high absolute risk factor levels in Singapore. And these are trends in mortality. Again, these data are from the Lancet series in Southeast Asia published in 2011. And these are trends in selected causes of death in Singapore. And as we can see, deaths from infectious diseases have been going down. These are deaths from tuberculosis, sharp decline in TB death rates over the last 5 decades. But let's look at what's happening to cardiovascular disease death rates. Actually, there's a plateau. And so no change over the last 5 years, and that's in contrast to other high-income countries where actually there has been a decline, even in crude death rates. So it's not just aging population. Death rates have been on the decline, but CVD death rates have not gone down. And Singapore is a high-income country, it's a small country, and prides itself on having the lowest infant mortality rates. But there's a disparity here. I mean, to catch up on CVD death rates. Right? So more needs to be done for cardiovascular disease. And now we've seen for high blood pressure in Singapore. And we know from numerous trials, this is a meta-analysis of over 1 million patients who were included in several trials. And you can see that reduction in blood pressure reduces coronary heart disease and stroke. And that reduction and this benefit is evident in young adults as well as older adults, and greater at higher levels of baseline blood pressure. So blood pressure needs to be reduced in younger population as well as in older population. That benefit is clear. And what's happening in Singapore? Well, there's a crude prevalence of hypertension among residents aged 30 to 69 years in the most recent NHS or National Health Survey. So almost a quarter of the population, of the adult population, has high blood pressure shown here in Singapore. And so almost 1 in 4 and 1 in 3 in the Malays. Malays comprise about 30% of the population in Singapore. So there is some ethnic disparity there.
Is there something unique about Malay women?
About Malay women?
The rates are much higher.
Yes, so rates are much higher in Malay women. I think they're obese, levels of education are low, and there is some income differentials in the Malay population. We'll talk about the Malay population a little bit more. So sometimes people say that actually ethnicity may be a proxy for socioeconomic disparities. Don't look at income, just look at the ethnicity in Singapore. And Malay is your low SES, low socioeconomic status. And maybe probably more markedly so in amongst women as we see here.
So rather than being something metabolic, it's more likely a proxy for social status.
In Singapore, perhaps. In Singapore, and this is striking because if you look at other low-income countries, we're seeing that hypertension is perhaps more common among women in other. So maybe it's access to care, maybe it's addressing more proximal determinants, and so it's obesity, is BMI, it's all of those things. We haven't looked at that here, but perhaps that's what it is. So if you look at prevalence of undiagnosed, so this is unawareness, and so about, again, 1 in 4, and this is in contrast to Canada. And again, Singapore is small, it's a high-income country, we shouldn't expect so much, and Canada's achieved better. So 1 in 6 are unaware in Canada, but 1 in 4 in Singapore. And if you look at prevalence of poor BP control among known hypertensive, this is what the NHS has published. So almost a third. So a third of known hypertensives are poorly controlled. If you combine these figures with that figure, you'll see that almost 50% of patients with hypertension have poorly controlled blood pressure. And if you look at the Malay population, you'll see that 75% of Malays have poorly controlled BP. So clearly, again, that ethnic disparity is very striking here. Let's look at what they are being treated with, and I'll highlight why this is important. So if we look at the use of antihypertensive agents here, we see that about 60%, so 2/3 of the population are being treated with. So first of all, there's very little published on use of antihypertensive agents, but amongst what was published, about 60% are using beta blockers, and about 64% are using just one class. So it looks like the vast majority are just being prescribed, the majority are just being prescribed beta blockers as a single agent or as a first-line antihypertensives and only one agent. And why is that important? Well, it's important because beta blockers, in fact, are not recommended as the agents of choice for treating hypertension anymore. If we look at these are data from the recent Cochrane systematic review where they've compared beta blockers to either placebo or no treatment, beta blockers versus other agent diuretics, beta blockers versus calcium channel blockers, and versus ACE inhibitors and ARBs. So yes, so beta blockers may be better than placebo or no treatment for treating hypertension. You see this is risk reduction for stroke or cardiovascular disease, but they are not better than diuretics or calcium channel blockers or ACE inhibitors and ARBs. And these are the trials that we have studied, a head-to-head comparison for risk reduction for either coronary heart disease or stroke mortality. Hence, the NICE guidelines, the British Hypertension Society guidelines, and the European guidelines do not recommend beta blockers as either first-line or second-line antihypertensive agents anymore. Beta blockers are, in fact, if any, fourth-line agents, unless there's a compelling indication, like post recent MI or heart failure, where you absolutely need to use it for controlling tachycardia or something like that. Otherwise, beta blockers are not recommended anymore, but that's not the case in Singapore. So just to sum up the challenges.
Sorry to interrupt there, but I mean, I guess maybe as a reciprocal finding based on the use of beta blockers, but strikingly low use of diuretics in this population, where here the JNC guidelines recommend that as the first line therapy. So maybe you're going to talk about the causes of that, but it's
yes.
only 15%, I think, on diuretics
yes.
is very low.
Yes, and I think we see that pretty much universally, that there's growth on the use of diuretics are not used commonly at all. And why is that? Is that because of the drug companies promoting other agents, or just lack of familiarity? But that's right. Diuretics are not used as commonly. So just to sum up the challenges: persistently high CVD death rates, suboptimal blood pressure control, high comorbidities, and high use of beta blockers as first-line antihypertensive. And these challenges are what we need to address. And again, given the current health system of Singapore. And Singapore has a mixed model of public-private healthcare system. Almost 4% of the GDP is spent on healthcare, which is actually very low. The outpatient of Singapore is served by subsidized government polyclinics, and there are about 18 polyclinics scattered around across all of Singapore. Half of them are serviced by this group called National Healthcare Group, and half of them serviced by the SingHealth group. And there are 400 GPs in these polyclinics, and these I'm going to come back to how heavily they are subsidized. And in addition, there are about 2,000 private general practitioners across Singapore. Both work on a fee-for-service model, but as I said, the polyclinics are very heavily subsidized, and as a result, about almost 70% of the population, of the Singaporean population, seeks care from the polyclinics. The NHS data indicate that about 45%, and that may be a little bit of an underestimate, that almost 45% of individuals with a chronic disease condition like hypertension or diabetes visit polyclinic. And as I said, when visit polyclinic, the GP consultation fee, the diagnostics, and the medications are heavily subsidized. And so, depending upon which drug you're prescribed, it could be the price could be subsidized to about 50 to 75% of the actual cost of the medication. But then also only the single drug formulation antihypertensives are on their formulary and are subsidized. And I say that because there are also in the market fixed dose combinations of two antihypertensive agents, and we know that the combination medications generally use lower dose and so have fewer side effects and compliance. This is again a pooled analysis of trials comparing two drugs, comparing fixed dose regimens with single agents, and the compliance to therapy and adherence with fixed dose regimens is better than single drug regimen. So these are not subsidized, and you'll see why the relevance of this will be apparent in a second when we talk about the trial that we are proposing. So given these challenges and our aim of improving blood pressure control, if we look at the literature, which implement strategies will work or have been shown for blood pressure control. Well, we know this, again, this is a Cochrane review, and we know from evidence that just going and educating the physicians, for example, as a single intervention is not very effective. You see the systolic blood pressure reduction before and after intervention in terms of millimeter reduction. You can see very modest benefit. Just educating the patient, very modest benefit. Similarly, nurse-led or nurse practitioner-led intervention as a single intervention, yes, some benefit, but modest, right? Likewise, just single intervention, single strategy will have modest benefit, but if you combine these and have multi-faceted intervention where you combine many strategies together, you get a much marked benefit, which is apparent here. So organizing care and packaging several of these strategies together produces much marked benefit. And our own trial that we did in Pakistan, for example, the control of blood pressure and risk attenuation, we found sort of a similar results. Now in this trial, this was a community-based trial of hypertension control, where it is a cluster randomized trial where we had done in a factorial design way, where we had two different strategies, tried either single approaches or combined approaches. And the approach was, the comparison was with no intervention, which was usual care. And then in some clusters we had just the trained physician training only. In some clusters we had the home health education through lay health workers. And then in other clusters we combined these two strategies, home health education plus physician training. We followed the patients over 2 years, and at the end of 2 years what we found was that single approach of training physician versus usual care was no better, right? So it was not beneficial. Just home health education was also no better than doing nothing. But when we combined the two interventions together, we found a synergistic benefit. The interaction was significant, and so this was better than either single intervention or doing nothing. So combining intervention produces some kind of a synergistic benefit. The combined intervention was also more cost effective than either single intervention or usual care. So in terms of blood pressure reduction for the dollar spent, it was more cost effective. This is incremental cost effectiveness ratios, and I'm not going to go into the details of that. We also did a projected CVD disability adjusted last year averted, and that was also more cost effective from a societal perspective, from the government and the payer perspectives. And so in a nutshell, the combined strategies work and the single strategies are not more beneficial. So using the same principles in the Singapore setting, how do we design a trial? And this was again just for blood pressure reduction, and as I said, there are a lot of comorbidities in Singapore. One of them, as I highlighted before, was the high lipid levels, and how do we integrate that? And we've known again from trials that statins in high use and hypertension, especially in hypertensive with additional risk factors, have a mortality benefit. And this is again trials of hypertension, trials in which in patients with hypertension with additional risk factors. So if the number of risk factors are too few, then perhaps the benefit is not so apparent. But in trials where the number of risk factors were 2 or greater, or for example in the Jupiter where they had the high CRP, you can see that there is a definite benefit, a mortality benefit of using statins. So how do we integrate all this information and put that in a trial? So with that, we set our aims to determine the effectiveness of a structured, multi-component primary care program comprising of an algorithm-driven intervention using fixed-dose combination antihypertensive treatment and lipid lowering for high-risk patients, motivational interviewing and telephone follow-ups by a team of physician-supervised nurse practitioners and nurses on improving blood pressure and lipid management among patients with hypertension compared to usual care in the polyclinics in Singapore. And I'll go into the details of the intervention in a second, but just to underscore that this is a multi-component intervention that we are planning to do, and we will assess the effectiveness of that in the polyclinic setting in Singapore. And then to perform an incremental cost effectiveness analysis of the structured multi-component intervention in terms of cost per quality adjusted life years saved from a societal payer and participant perspective relative to usual care, to examine the economic impact of such a program from the specific stakeholders perspective, from the policymakers perspective, from the payers perspective, and from the patient perspective, and to determine the impact of the above mentioned program on adherence to antihypertensive and lipid lowering medications. And this is the overall design. It's a cluster randomized study. We will be randomizing by practice. That is at the polyclinic level. Again, this is not at the individual patient level, but the entire polyclinic will be randomized. We will conduct this at the 9 SingHealth polyclinics. The SingHealth polyclinics, again, the SingHealth is the group that is affiliated with the Duke-NUS. So our collaboration is sort of easier with this group. So the 9 SingHealth polyclinics, we will randomly exclude one, and the other 8 will be randomly allocated to either intervention arm, 4 to intervention, and then 4 to usual care. And then 500 patients from each will be included in the study, and it will be consecutive patients. So then there is no selection bias, even in the ones who are included in the study. The inclusion criteria is 40 or older, visiting one of the 8 SingHealth polyclinics, and would have visited this clinic twice a year during the last 1 year, and a diagnosis of physician diagnosed hypertension using the conventional diagnosis of hypertension. Intervention, as I said, is a package structured intervention. Algorithm, blood pressure goals for all, and fixed dose combination antihypertensive meds, and lipid management determined by cardiovascular risk level. And I'll go through the algorithm in a second. And then the other component is motivational counseling by nurses, and a structured follow-up over telephone and in clinic. The target audience for this training will be the physicians, nurse practitioners, also known as nurse clinicians in the Singapore setting, and then the nurses. So everyone will be trained in the algorithm for treatment. The motivational counseling, the nurse practitioners and the nurses will be trained in this, and everyone will be trained in the structured follow-up, although it will be delivered by the nurses and the nurse practitioners only.
Will the docs let you change the medications?
So it's interesting. The docs, we've had to go through a rigorous process of working with them and in collaboration with them, and in collaboration with the SingHealth physicians. And the SingHealth, there's a clinical cardiovascular risk group within the SingHealth, and we had to get their buy-ins for this. And so we worked with them and said, this is what it is, and then we developed the specific algorithm with them. So that process of buying, it took us almost 6 months to get here, and now finally they're all ready to introduce the new algorithm in their system. But it's a great question, and it doesn't come in, it takes time to get there.
Think they'll let them get off the beta blockers though?
Yeah, so we've developed it's again, I think once they're convinced, and it looks like they are, Singapore is also great. It has its challenges, but it's also great that I think once they're convinced that this is the way to go, that they would just do it.
That's what they do once they're convinced.
Once they're convinced, and I think
Whatever the Ministry of Health says.
Yeah, the Ministry of Health says this has got to be done, then this has got to be done. So I think that we have now developed that so they are willing to switch if the blood pressure is uncontrolled. But if the blood pressure is controlled, then, I think that makes sense. They do no harm. It's like, okay, fine. Although there is a benefit, we are looking not just at blood pressure. As we've shown, there's a endpoint is cardiovascular morbidity and mortality, but it's going to be a stepwise approach. So I think if we start with let's go with the ones who are not controlled, we'll get there eventually.
Just to follow up on that, do you have any way of checking to make sure that they are actually complying with the regimen exactly how they're supposed to be doing?
I think that's a great question. And again, this is an effectiveness trial. And we are going to train them, and we are not following and tagging each patient. In fact, we discussed this with them. How are we going to do this? How is this going to go through? When the patients come in, does it say that this is a trial patient? And we said, no, this is not how we are going to do this. We are going to train them. We're going to train the physicians, and then what they do is up to them, because this is a real world scenario. And this is what's going to happen in real life. If they don't take it up, then it's not effective. But this is a trial of training the physician, training them in the algorithm, making sure that the drugs are available, and subsidizing them. And then if it happens, it happens.
But will you be able to, because one of the lessons, obviously, I hope it works, but one of the things you can learn from this is why it didn't work. And will you have enough information to be able to do that based on monitoring it?
Excellent question again. So what we are doing is, and we'll talk about outcomes assessment, is yes, our main outcome is blood pressure change in the patient, but we are also looking at pharmacy records. We're also looking at clinic notes. we are also looking at the dispensing. So we look at so we look at how many patients switched, and the effectiveness. We'll track them according to that. So we're looking at process indicators, and we will have some of that information. Yes. So in the usual care, the 4 polyclinics, they will continue their existing practices, and the existing practices, everybody comes in the clinic, they have an excellent infrastructure in the polyclinics, by the way. Every patient walks in, everybody gets a computerized CVD risk score, the Framingham risk score, so what they do after they get the Framingham risk score is a big question. So there's a lot of variability in practice. They don't get the medications, don't generally get titrated. There's no structured titration of medication according to that. And I think that's what we're giving them, that this is what you do, this is the structure that you do. Sorry.
Are you collecting any information on the patients that might be helping you later on to identify those who are more adherent or more responsive to this? And I'm thinking particularly of things in my area like psychosocial factors like depression, conscientiousness, which is a measurable construct. It may be that if you got a little bit of a screen of these things, you might be able to identify patients who are more or less likely to respond or benefit.
So it's a good question. We're not administering any tool for cognitive functions per se, but it's a great question. We could consider including some of those. We are assessing, and we'll come to the tools that we are, to the questionnaires that we are giving, where it's a quality of life.
For example, social support, which families might help ensure that the patients are more likely to do it.
We are providing some of that through the nursing,
yes,
through the motivational interviewing, and through the structured telephone-based follow-up. So we're not so much relying on their home support system in that. We are providing some of that through the trial, but it helps. I mean, clearly, we've shown that if a attendant comes and we explain to the attendant, and if
the people, despite your best attempt to provide them with the support and the so forth that they could benefit from, some patients don't respond, and you find that those are uniformly the ones who don't have a very strong family support system. That might help you in the next version of this trial to somehow single those people out and try to target them at the outset.
It's a great point. It's a great point. Okay. So CVD risk scoring, subsidies on medications will be the same as the intervention clinic. Payment for services will be the same. However, physician, nurse in the usual care, like I said, will not be trained in the treatment algorithm, motivational counseling, telephone follow-up, because that's not part of routine care. So this is what we'll be doing during the screening assessment: socio-demographics, diet, lifestyle, EQ, 5D, 5L, SF12, anthropometric measures, blood pressures, again 3 times 5-minute interval sitting position, weekly through device. We are measuring fasting blood plasma glucose, lipids, serum creatinine, and random urine samples because we need albumin to creatinine ratios. And this is our treatment algorithm. They come in, they first get the CVD risk assessment. So anyone who's 80 and older will be sort of automatically goes into the low risk group, but age 40 to 49 will go into the high risk and low to medium risk. So if their risk is more than 20% over the next 10 years, they go to high risk. Otherwise, they go to medium or low risk. And the high risk will get the fixed dose combination. And the fixed dose combination is either a combination of losartan, hydrochlorothiazide, or telmisartan, or hydrochlorothiazide, because that's what's available in Singapore.
So not ACE inhibitor?
Not ACE inhibitor. Not ACE,
which is a problem in the Asian population.
Yes, with the cough. Yeah, and it's also not available in their system, so it doesn't work.
So 90 is the cutoff for treatment?
90 is a cutoff for treatment.
Isn't that high?
For diabetics?
And when do you start to treat?
90.
Not lower?
No.
It's interesting.
No.
And that's the practice in Singapore,
Yeah.
90?
90.
What's the practice here, Tom?
90.
90. Yeah, it's sort of, there's been a pendulum swing back because they're too low blood pressures, it turns out.
People get hypotensive on the drugs. Is that what people
Yeah,
are?
or they're just, you see more complications
in the other way.
in the higher risk groups in particular. Yeah. So.
Yeah. 90 is 90. That hasn't changed. I mean, your treatment targets are different, right? If you have diabetes, if you have chronic kidney disease, then your treatment target will be 130/80.
Right.
So treatment target will be lower, but
Right.
you would not start treating 135/85. You give them non-pharmacological advice. You do other things. Perhaps you may consider, if they have albuminuria, you could consider, but I think all the studies that are coming out, the cohort trial, the other trials, strict blood pressure control, aggressive treatment is actually increasing cardiovascular mortality. Increasing. It's actually having a difference. So people are sort of backing off with very aggressive, So I think conventional is the way to go as far as treatment is concerned.
So 140/90.
140/90. 140/90 as far as initiating treatment is concerned, and as far as treatment threshold is concerned, 140/90 unless you have diabetes. They're still, GNC 8 has not been released. They are still debating. They will. I don't know when it will come out. It has not come out because I think these issues have not been resolved. But we are going with the convention here. Right, and then BP controlled, not controlled. Again, we'll add a calcium channel blocker to that, and then low and medium risk, we are saying CCB, and then thiazide, and then is ARB in the low risk group. We're not so concerned about the choice of medications there, but in the high risk group, we are starting with the ARB thiazide combination in the high risk group. And then if not that, then if you've exhausted all that, then they'll be referred to the specialist. The motivational counseling, nurses will be trained in counseling approach intended to help the patient resolve problems and make decisions, to facilitate patient participation and empowerment, consider patient priorities and set goals for self-care, and especially medication adherence. And again, this training, and again, this was another thing that we had a lot of debate with the single nurses. How can you take them out for training, even for sustainability? They are busy and all that. So this training is going to be provided over 3 hours. It will be condensed. It will be interactive discussions, demonstration videos, and then the first encounter is going to be with the patient is going to be for 30 minutes, and then a follow-up is going to be over the telephone, and then telephone follow-ups every 4 weeks for the first 3 months, and every 3 months, and then there's going to be checklists in the chart with action plans and sign-off by nurses and discussion with physicians. Clinic follow-ups, which is a regular practice and should be with physicians until BP is 6 to 8 weeks, and then every 3 to 4 months as indicated. Outcomes assessment.
So, Tazeen, can I ask you about that? Just you made the point there, and this is going to be kind of a critical issue. Obviously, is the nurse participation. I mean, in addition to the training time, it's more time spent doing this sort of follow-up. I mean, how is that going to be operationalized? Yeah. Do you have somebody? I mean, can you hire somebody to do that, or how are you going to? What's the strategy?
Yes. So there is going to be impact on resources, and most impact on resources is going to be on the nurses. But there is a task shifting. What we expect with this is that you're going to get better blood pressure control, and these patients then eventually, in the long term, are going to stay out of the clinic. But someone's going to do that. We also expect that these follow-up calls are not going to last for more than, because this is hypertension. It's not, what is it, what was your home BP? I think that's fine. And these calls will take 3 to 5 minutes, not longer than that. People are used to saying you call somebody for diabetes. Now those calls are longer because you're titrating insulin, they can 15 to 20 minutes. And there are other trials.
And they're doing those in the polyclinics.
They are doing those in the polyclinics now. But for hypertension, it's a shorter call, and in the long run, you keep the patients out of the clinic. So that's what you got something.
Yeah, so, but it's 500 patients in the. I mean they'll feel that workload. I would think.
They will
right?
feel, yeah.
In the short term.
Yes.
So the motivational interviewing by the nurses is a fairly important part of this. Is the motivational interviewing training they're getting based on some kind of evidence-based system that's already been used in other places?
Absolutely. In fact, that system is already in Canada, Heart Stroke Foundation, so they use that. And So, like I said, outcome at 1 year, outcome assessors will also review the clinic, pharmacy, records of all patients at 4 months for hospitalization, GP visit-related costs, information on medications and adverse events. So that will be the process. We are looking at the process and the outcomes. Effectiveness measures will be reduction from baseline to follow-up at 1 year post-randomization, proportion of patients with BP control to target, or more than 10 millimeter reduction in systolic BP, and proportion of patients with LDL cholesterol less than 100 milligrams per deciliter, or a decrease of more than 15 milligrams per deciliter from baseline. An analysis is an intention to treat, and we have a neat, I think this is very sophisticated, some of you must have used this approach, a sequential closed testing procedure where you actually have to satisfy all four. So you start with a change in SBP, so first you satisfy that, refute the null, then you move to change in LDL, you refute that, then you have the categorical reduction in systolic blood pressure to your set criteria, and then the categorical reduction in LDL. So you actually have to satisfy all four, each of the four criteria, to then say, yes, this is a successful program. So I think we're setting pretty high standards. This is an intensive program, but then to say, yes, this is successful, you do have to meet all the criteria, each of the criteria. It's the model that we're going to build is a logistic mixed effects model, random effects for polyclinics, patients, and treatment effect nested in the patients, fixed effects for time, and treatment effect or follow-up. We have a number of secondary outcomes, including each of mortality, CVD death, change in albuminuria, CVD risk for individual outcomes, change in lifestyle, and our cost effectiveness outcome will be change in QALYs from baseline to point and follow-up at 1 year. And then some of you will question, we're looking at change in QALYs at 1 year. Isn't that too ambitious? Well, we are switching people from beta blockers, and beta blockers are notoriously known to have more side effects. Then we're also giving them fixed dose medications which have lower in terms of quantity of antihypertensives, so side effects will be lower. So we expect that there will be a change in QALYs, and certainly in some domains, so we do expect to capture this. And again, we're setting pretty high standards for the outcomes, but if we do expect that, then I think it will be very, very robust. Perspective, from the policymaker's perspective, costs of intervention, any subsidies, all of these will be accounted for, diagnostic and medication. From the payer's perspective, any direct payments of third parties, including employees, or self-insurance. For example, in the Singapore setting, you have the Medisave, with a mandatory savings for health, productivity loss by the patient or caregivers, and from the patient's perspective, it account for any direct cost productivity loss incurred by the patient. Then finally, our final outcome is adherence, and we'll have a composite. We look at adherence to antihypertensive as well as lipid lowering, and these data will be directly extracted from pharmacy dispensing records. Sample size, again, it's pretty adequate, and these are the details for if anyone's interested. Our committees and oversight, we have the Singapore IRB, we have an independent DSMB, it's a 4-member DSMB, and again, we have a statistician, a clinician, and 2 clinicians, one from Singhealth, one from Duke-NUS, and an epidemiologist. We have a steering committee with an independent chair, where we have a trials management committee. And implications, of course, for sustainable hypertension program will provide compelling evidence for upscaling the program across all the primary care centers in Singapore, and then such a program will also serve as a platform for delivering other chronic disease conditions and other Asian countries with similar ethnic population and healthcare infrastructures. And this is our team, co-eyes, and that's it. Thank you.